guys, look, I have my checklist, okay? This is the first time you're doing the respiratory assessment, so I want you to use your checklist, all right? It's on Blackboard, it's under week 3, write notes, whatever you want, but I want you to use your checklist, okay? Because this is the first time you're doing it. Right now, don't memorize anything, get comfortable, get confident, all right? And then you can start memorizing. Okay. Knock, 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 hand hygiene. Hi, my name's Jen and I'm going to be your nurse today. Can you tell me your name and date of birth, please?
Talia Leibowitz, September 19, 2005.
Talia, may I see your bracelet, please? Talia Leibowitz, September Do you have any allergies, Talia?
No.
Okay. And do you have any cultural concerns that I should be aware of?
No.
Okay. I'm just going to pull this curtain so that we have some privacy. And I'm also going to raise your bed so that I'm not leaning over so much. Is that all right with you?
Yes.
Pull my curtain, providing privacy. Are you warm enough? Would you like a sheet or a blanket?
I'm okay.
Okay. All right. So I have my bed to my appropriate height. I have verified my patient's name, date of birth, and allergies. I did hand hygiene. I provided privacy. I offered her a sheet, which she declined. And I raised the bed up to proper working height so that I'm not constantly leaning over like this. You guys are new practitioners. We don't want you to harm your backs yet, okay? So the first thing I'm going to do is I am assessing. I'm looking with my eyes. I am assessing her respiratory rate. I'm looking at her chest, okay? Does it rise and fall symmetrically? If it does not, that's a problem. That's called flail chest. You don't need to know that now, but just know that if her chest does not rise and fall symmetrically, that is a problem. So her chest, both the left and the right side, are rising and falling at the same rate. It is symmetrical. I am looking at the rhythm, the depth, and I am also looking at the effort of her breathing. Her breathing is quiet, it is effortless, it's easy. Those, we could use any words you want. It is within normal, we don't want to say normal. We want to say within normal limits, or you could say it's easy, it's effortless, it's quiet, it is appropriate. So, chest rises and falls symmetrically. Her respiratory rhythm, rate, and depth are quiet, easy, and effortless. Could you tilt your chin up to the ceiling? I'm looking at her neck, and I'm looking at accessory muscles. So I'm looking at the muscles above the clavicle. I'm also going to look at the muscles of her chest and her abdomen to see if she's belly breathing. Belly breathing is like, you'll see babies belly breathe a lot. So I'm looking to see, is she using any extra muscles? So I will assess the muscles in her neck. Can I read your gown?
Mm-hmm.
Okay. I am assessing the muscles in her abdomen. Okay, she's not belly breathing. I don't see any intercostal retractions where that's the space in between the ribs. And if you had intercostal retractions, the skin, the muscle, the tissue, all of that would be going in when she's breathing. So no intercostal retractions. She is not belly breathing. She is not using any neck muscles. So again, her breathing is effortless. Okay? All right. Now I'm going to inspect. Could you sit up for me? Can I lower your gown? So now what I'm looking for is I am assessing her anterior, posterior, lateral dimensions. So you are twice as wide as you are deep. So that is a 2-to-1 ratio, okay? So she is twice as wide, anterior, posterior, lateral dimension. So her AP lateral dimensions are 2-to-1. If it were 1-to-1, she would have a big round chest. Something called chronic obstructive pulmonary disease, you have these big floppy lungs, and the chest cavity has to expand in order to accommodate these big floppy lungs. So that is called barrel chest. When you see someone that's got a big wide chest where they are as deep as they are wide, that could be a very strong indicator of chronic obstructive pulmonary disease or COPD, okay? So I'm inspecting her chest dimensions. May I see your nails? I am looking at her nails. I am looking to see any blueness in her nails, okay? I'm checking capillary refill, although yes, that is part of our cardiac assessment. We can still do it in respiratory. I'm looking at her skin condition, okay? I'm looking at the skin on her chest. I'm looking at the skin on her back, okay? I'm also looking at her spine. I'm looking to make sure that the spine is erect and straight, midline. I'm also looking at her shoulder blades to see if her shoulder blades are even. What is it called when the spine's curved?
Scoliosis.
Scoliosis. So I could also have, if I had any doubts, I could have my patient stand up and touch their toes, and then I could look at the spine straight on. So I'm looking, there are no spinal deformities, shoulder blades are even, skin color is appropriate for age and ethnicity. There's no ecchymosis, there is no redness, there is no excessive warmth. Okay. Her respiratory effort, again, is even, it's unlabored, it's quiet, effortless. There's lots of different words you can use. So now I'm going to palpate the trachea, all right? Can you put your chin up too? Okay. And right now I'm feeling for any lumps. I'm also looking to see if there's any tenderness. If there was any tenderness, she would maybe flinch, right? So I'm just palpating gently along the trachea for anything that might feel abnormal. So trachea is midline, no abnormality stuff. So when I look, is her trachea under her chin? Is her trachea midline? Okay. So now I'm going to palpate her chest. I'm going to use the palms of my hand because that gives me more surface area. So 3 anteriorly, 4 posteriorly, but you'll see I don't just palpate the front. I also palpate laterally. What I'm feeling for is lumps, bumps, redness, warmth, tenderness, anything abnormal, okay? I'm gonna put my hands on your chest and feeling for any abnormalities. Okay. And then abdomen, and then I go laterally, right, to feel the lateral side, and I do the exact same thing on her back. So I palpate. And then lateral. Okay, so chest, no abnormalities notated upon palpation of the chest. And now I'm going to check for, it's called chest excursion. Can I just get you to stand up for a second?
Take the gown off.
Yeah. And what we're looking for, again, is we physically look to see when she breathes, is the chest symmetrical? Does it expand and contract at the same time? Well, now we're going to feel. So you're going to go to the costal angle, which is right where the ribs end anteriorly. You're going to place your hands, and you're just going to pinch in just a tiny bit of skin. Take a deep breath in. And what you're looking for is for your hands to move symmetrically. So we do that anteriorly. Turn around. And we're also doing it posteriorly. Again, you put your hands at the base of the ribs, the costal angle. Pinch in just a little bit. Take a deep breath. Okay, so chest expansion posteriorly and anteriorly is even. If it's not, it could be a deformity of the lungs. It could be a deformity of the ribs. We won't worry about that right now. Okay, so now I'm going to palpate for what's called tactile fremitus. That is a vibration in the chest. Again. We will start posteriorly, and you can either use the palms of your hands or you can use the ulnar surface. It's up to you. I like palmar. I feel like you cover a larger surface area using your palms. You're going to have your patient say 99 each time you move your hands. You will feel a vibration. If that vibration feels different in the top versus the bottom, it could be a consolidation, meaning there's something there that shouldn't be there. It could be filled with fluid. It could be filled with mucus. It could be filled a tumor. It could be something is there. So that might be your first indication that we need to dig a little deeper, okay? I'm going to place my hands on your back, and I want you to say 99 every time you feel my hands move.
99, 99, 99.
Notice I went three down, and now I'm going to go laterally.
99.
99. Thank you. All right, turn around. Okay.
99, 99, 99.
Okay, so tactile fremitus is within normal limits. I'm not hearing or feeling anything that makes me concerned. We're going to percuss. Now, percussion is a higher level skill, but I'm teaching you this, and I want you to practice so that you put it in the vault so that when you come back here, God bless you, for nurse practitioner school, you already know how to percuss, all right? So one of the things we never do is we don't listen or feel over bone, okay? You want to feel over the intercostal space. If you are listening or feeling over bone, it's going to be inaccurate. Also for women, you can't listen over breast tissue. There's too much here for you to be able to hear through and to be able to feel through. So with percussing, we're going to percuss 12 places anteriorly, 14 places posteriorly. If you find the clavicle, that first space underneath, that gives you a really good indication of where the intercostal spaces are. So with percussion, I want you to think middle, middle, middle. You're going to take the middle finger of your non-dominant hand. You're going to take the middle finger of your dominant hand and you're going to tap on the middle bone. So middle, 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 okay? My middle finger of my non-dominant hand, my middle finger of my dominant hand, and I'm tapping on the middle bone of my non-dominant hand. Now you're going to hear a noise, whether it's dull or resonant or hollow. You guys don't need to know that yet. I just want you to know the technique on how to percuss, okay? So, 1, 2, and you can feel bone, so you'll know if you're in an intercostal space or not. 3, 4, 5, 6. Can you shut that door? Thank you. 7, 8. Now, we can't percuss over breast tissue, right? So, can you raise your breast for me? 9, 10. I'm sorry. 11. 12. All right, turn around. So, again, we don't percuss over bone, so we are avoiding the scapula, all right? So, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and then 13, 14. And remember, we do everything skin to skin, all right? I don't want to see anybody listening to lungs over a bra, over a gown, okay? Now I'm going to listen. That's the final step, okay? I'm going to auscultate 12 places in the front, 14 places in the back. I'm going to ask you to take deep breaths. I don't want you to really take deep breaths because I don't want you to pass out. But for anteriorly, we always start above the clavicle. And again, we're listening in the intercostal spaces. We're not listening over bone. We're not listening over breast. We're not listening over clothing, okay? All right. I want you to take a deep breath every time you feel my stethoscope move. So 1, 2, 3, 4, 5, 6, 7, 8. Can you lift your breast again for me? 9, 10. Now with 11 and 12, we go lateral. 11, 12. Okay, turn around. With posterior, we start above the scapula. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, nope, stay that way, 13, 14. So as you go down, you're tracing the scapula. You're not listening over the scapula, you're going right around it. And then as you get to 10, 11, 12, 13, 14, you're listening more laterally so that you can listen to the sides of the lungs. Questions, comments, concerns? Yes?
When you percuss, do you also go more laterally as you go down?
Yes. Also, we always listen side to side. You're not going to go straight down the left side and then straight down the right side because you want to be able to compare what you're hearing on both sides of the lungs. Are you hearing crackles on the left? Are you hearing crackles on the right? Are you hearing crackles on both? Any other questions? Okay, well then everybody except for Professor Newman in a gown, grab a sheet. You're going to be practicing. Since